Peace. Welcome to the YouTube live book reading of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. I'm your moderator and narrator, Urel Neveu Riley. Peace, YouTube. What's going on? Happy Sunday. It gave us a little bit of time to chew on that. We had a beautiful day yesterday. Oh, look at that love. And look at this. Wow. Zaza Ali put together this masterpiece. And yesterday I had the honor of receiving my copy and meeting her, the Oracle herself. All right. So we pick up in the 24th chapter in the middle, page 370. Closing volumes and PEEP. The closing volume pulmonary function test has been discussed in chapter 3. It is believed to represent the point in the exhaled vital capacity at which flow ceases through the small airways of the gravity-dependent areas of the lung. Teleologically, this concept is very attractive since it would assure the maintenance of a minimum gas volume within these dependent alveoli and help prevent their collapse. Interest in this pulmonary function test increased when it was noted that patients with chronic obstructive pulmonary disease, COPD, had significantly increased closing volumes. It was theorized that early changes in closing volume may signify early small airway disease, a theory that is seriously questioned at present. It was also hypothesized that COPD patients with closing volumes greater than FRC may suffer significant hypoxemia because a portion of the tidal volume cannot be distributed to basilar alveoli. It must be understood that although the existence of closing volumes is generally accepted, their measurement and physiologic significance are highly questionable. What few data are available concerning PEEP and closing volumes do not justify the sweeping assumptions made by some investigators and authors. There is no direct evidence to support the hypothesis that PEEP directly affects closing volumes. The observation that PEEP may alter the relationship of FRC to the closing volume is attractive. However, to assume that this is the mechanism by which PEEP improves arterial oxygenation is misleading. The direct effects of PEEP on airway patency, inspiratory flow through small airways, and closing volumes are undocumented at present, whereas the direct effects of PEEP on FRC are well documented. We strongly urge that PEEP therapy be clinically conceptualized and rationalized primarily in terms of its effects on FRC, although the future may reveal the existence of a significant relationship between PEEP and closing volumes. At present, the relationship is speculative and presumptive. All right. Middle of page 371. Common pathophysiology requiring PEEP therapy. Welcome, YouTube. Thank you. Thank you. Welcome to the peaceful, quiet part of YouTube where we read books and learn from masters. Thank you so much for reading with us, part of the book lovers community here, live from the light in LA. Wish you had all a beautiful day. Peace, peace. First day of the week. The major therapeutic application of PEEP is with acute restrictive disease processes in which the FRC has been significantly decreased. See Figure 21, Type C. This type of pulmonary pathology presents two major physiologic abnormalities that are potentially life threatening. One, increased intrapulmonary shunting, QS over QT, and two, decreased lung compliance. The increased intrapulmonary shunting is mainly due to collapsed alveoli with perfusion through the adjacent pulmonary capillaries. Inevitably, this occurs primarily in the gravity dependent portions of lung. Since pulmonary artery blood, mixed venous blood, is passing through the lung and entering the left heart without the opportunity to oxygenate, the administration of increased oxygen to open alveoli will have little effect on the oxygen content of the blood in the left heart. Very key. Thus, a refractory hypoxemia exists, i.e., an arterial hypoxemia that is essentially unaffected by breathing increased oxygen concentrations. The decreased lung compliance is primarily due to the disease process and secondarily due to the acute lung volume loss. Not only is the significant drop in FRC responsible for inspiration occurring on a less advantageous portion of the compliance curve, but often the disease process is responsible for shifting the curve to a yet more disadvantageous slope. It is essential to realize that both of these pathophysiologic factors result from a particular type of acute lung volume loss, i.e., an acutely decreased FRC with significant decrease in residual volume. See Chapter 20. These patients often have very adequate ventilatory reserves, expend a great deal of energy to spontaneously ventilate, and manifest significant alveolar hyperventilation, decreased arterial PCO2. This significantly increased work of breathing is accompanied by a significant arterial PO2 deficit that is relatively unresponsive to oxygen administration. Clinical goals of PEEP therapy. PEEP therapy is capable of accomplishing three primary clinical goals when appropriately applied. One, improvement in arterial oxygenation. Two, decrease in work of breathing. And three, improvement in V over Q inequality, improvement in arterial oxygenation. When a refractory hypoxemia is caused by intrapulmonary shunting secondary to diffusively decreased FRC, the application of PEEP usually results in dramatic improvement of arterial PO2. The distribution of the increased lung volume will tend to favor the collapse or nearly collapsed alveoli. Once these alveoli are adequately re-expanded, concentrations of inspired oxygen below 40% will result in adequate arterial oxygenation. Peace, peace. Highest heart love. Thank you so much for reading with us. This peaceful part of YouTube where we read books and learn from masters. So we are reading clinical application of respiratory care for the next generation, aspiring rep techs, M techs, nurses, physicians, and doctors in the respiratory care. So thank you so much for being here with us. Oh, I'm in the middle of a live. I'm reading. Yes. Live. See? You gotta love it. Improvement in V over Q inequality. Increasing FRC toward normal will improve the ventilation perfusion relationship. Not only will shunt effect be diminished, but dead space ventilation will be decreased in most instances. Yes. Decrease in work of breathing. When acute restrictive disease exists, if the FRC can be increased toward normal, inspiration will begin from a more advantageous point on the compliance curve. This improved compliance results in less energy required to move the same tidal volume or minute volume. Yeah. All right. And summary. When applied to an acutely decreased FRC secondary to reasonably homogeneous lung disease, PEEP will dramatically improve compliance, decrease true shunting, decrease dead space ventilation, and decrease shunt effect. Adequate arterial oxygenation, PO2 of 60 millimeters Hg or better with normal hemoglobin may be accomplished with 40% inspired oxygen concentrations or less. In a spontaneously breathing patient, the PEEP will result in much less work of breathing, while any necessary positive pressure ventilation will be accomplished at significantly lower airway pressures. In our experience, therapeutic levels of PEEP in the adult are usually between 10 and 30 centimeters H2O. Generally, higher PEEP levels are required with CPAP or low IMV rates than with control mode IPPV. The overall clinical goal of PEEP therapy must be to assure adequate tissue oxygenation. Thus, the pulmonary advantages must never be evaluated separately from the cardiovascular effects and other potential detriments of PEEP. Undesirable cardiopulmonary effects of PEEP therapy. Top of page 373. When applied improperly or when not indicated, PEEP may manifest three undesirable cardiopulmonary effects. One, decreased cardiac output. Two, increased intrapulmonary shunting. And three, decrease lung compliance. It has been previously stated that PEEP increases mean airway pressure, decreased cardiac output, thereby may increase intrapleural pressure. This increase in intrapleural pressure may potentially decrease venous return to the heart and thus decrease cardiac output. See chapters 26 and 27. No matter how strong the heart may be, it cannot pump more blood than comes to it. Tissue oxygenation cannot be maintained or improved by decreasing cardiac output. Therefore, if PEEP is to be of physiologic benefit, it must not cause significant decreases in cardiac output. The decreased venous return secondary to PEEP can usually be reversed by appropriate fluid therapy. See chapter 27. However, in some circumstances, the cardiac output may be improved pharmacologically. These are medical judgments and must be made individually for each patient. However, if PEEP therapy is causing decreased cardiac output that cannot be reasonably reestablished, that level of PEEP therapy is contra- contraindicated. Contraindicated. It is our experience that almost all patients in whom PEEP therapy is clearly indicated have few problems with decreased cardiac output that cannot be readily overcome with proper fluid therapy. This is probably because such patients have a significant portion of the increased airway pressure dissipated in providing the necessary distending pressure to improve FRC. Therefore, a relatively small portion of the increased airway pressure is apparently transmitted to the pleural space. When PEEP therapy causes a significant decrease in cardiac output, two questions should be answered. One, is the pathologic process one that should benefit from PEEP? And two, is too much PEEP being applied? Peace, you two. Welcome. We're in the 24th chapter. Welcome to the peaceful part of YouTube where we read books and learn from masters. So, highest heart love and honor, respiratory care for the people for free on this peaceful part of YouTube. Clinical application of respiratory care. We're in the 24th chapter, page 374 at the top. Increase intrapulmonary shunting. This is key. Since a primary goal of PEEP therapy is to decrease shunting, there can be no argument that if PEEP causes increased shunting, it is contraindicated. PEEP most likely results in increased shunting, where over distension of reasonably undiseased alveoli results in decreased perfusion to those alveoli. Such a process may favor pulmonary blood flow to decreased areas of lung unaffected by the PEEP. This is believed to occur most frequently when PEEP is applied to lung disease with fluid filled alveoli or airway obstruction, e.g., bacterial pneumonitis or multiple lung abscesses, non re expanding segmental or lobar atelectasis. It may also be hypothesized to occur when too much PEEP is applied or when PEEP is applied to a normal lung. No matter what the etiology or how controversial the theory, one clinical statement remains irrefutable. PEEP therapy that results in increased intrapulmonary shunting is contraindicated. Middle of page 374. Decrease lung compliance. Over distension of the alveoli results in decreasing lung compliance. See Chapter 3, as well as decreasing chest wall compliance. Therefore, too much PEEP may result in decreasing pulmonary compliance. In most circumstances, decreasing compliance resulting from an increased PEEP is an indication to decrease PEEP therapy. Let's see. Let's see. All right. Let's go this last paragraph and then we'll pause and continue. Bottom of page 374, monitoring PEEP therapy. Oh, let's go. Monitoring PEEP therapy. All patients with refractory hypoxemia and increased work of breathing will not favorably respond to PEEP therapy. In addition, PEEP therapy may cause harm when inappropriately applied. These statements lead to the inevitable conclusion that PEEP therapy must not be applied without appropriate monitoring. The term appropriate is a clinical judgment and varies widely for different patient populations and different health care institutions. The following discussion is designed as an organized and objective discussion of monitoring techniques from the simplest to the most complex. They are presented so that the respiratory care practitioner may be familiar with their potential application. Their actual applications must be based on clinical judgment and availability. There are three general areas of monitoring that are applicable to PEEP therapy. One, airway pressure and gases. Two, hemodynamics. And three, oxygenation. We'll pause right here. Maybe back with the 24th chapter, clinical application of respiratory care, by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. In the 24th chapter, section 6 of this beautiful, masterful book. Thank you so much for the likes, the subs. We're pushing towards 600 subs in this peaceful part of YouTube where we read books and learn from masters. I'm Master Fitness Trainer Uriel Navarre Riley. Highest heart, love, and honor. Thank you so much for shaking it up on YouTube with us reading high level books for the people, right? I will put the vocabulary in the description. Much honor and love. I wish you have a wonderful evening and day. We're going in to another beautiful week here. All right. So let's keep our heads focused. Remember, focused energy vibrates high. Hey ya, hey ya, hey ya, hey ya, hey ya, hey ya, hey ya. Hey ya, hey ya, hey ya, hey ya, hey ya, hey ya, hey ya. Shaking it up. Peace, peace. Much love. Oh, look at that. Oh my goodness. So much love from around the world. Wow. Man, thank you, Mrs. Melody Moore. Highest heart love. Thank you to all the light workers for playing our part. All our friends and family. Let's have a glass of love water. We're going to have a beautiful rest in the pink cloud tonight. Highest heart love. Love you. Thank you so much. Mm. Oh, I love you. I love you. I love you. I love you. been a beautiful, beautiful manifestation of a day and evening. We are at the new moon in Virgo, grounding energy, earth energy. You have to stay grounded. Grounding is the reality. It's the now. You're in a peaceful place right now. So I want you to have a wonderful, wonderful week. I will be back and see you soon when we reconvene. Chapter 24 of this book reading. Thank you so much for having a glass of love water with us, for reading with us, and breathing with us. I love you. I love you. You know it, because I love myself. Thank you so much to all the light workers out there doing the work, all the book readers, book lovers community. Thank you again to the one and only Zaza Ali. You did it. You did it. Thank you for all of your work. All right. I'll see you soon. Peace, peace.